Okay, so what we have discussed much earlier is about the complete renal pathology. We discussed the normal histology, the different microscopies, the kind of deposits, glomerulonephritis, everything. So this is completely an image-oriented session of the renal pathology. So let's rush through the images over here. So most of the images are from your textbook Robbins only. So this is what we are talking about, the normal light microscopic appearance of the normal glomerulus. So these outermost cells which are yellow in color, these are nothing but the parietal epithelial cells, and these blue colored cells are nothing but the visceral epithelial cells. For understanding purpose, these food processes are shown over here, but normally on light microscopy you couldn't appreciate these things. And these green colored cells are nothing but the mesangial cells, and these orange colored cells are nothing but the endothelial cells. Endothelial cells of the nothing but the fenestrated endothelium. You can also appreciate the fenestration seen over here. These are the fenestrations, and the size of the fenestration is almost up to 70 to 100 nanometers. Yeah, and in between there is a maroon colored linear structure. See, if you could able to make out this structure, see this one. Yes, this maroon colored linear structure is nothing but the glomerular basement membrane. So this is all about the structure of the glomerulus. Hope you understood this. And we have clearly discussed all the other features of these things. Okay. So once again go through these things. This is the parietal epithelial cell. This blue colored cell is a visceral epithelial cell. And these green cells are the mesangial cells. These brown colored cells are the endothelial cells. And this maroon colored structure, what you are looking at, is the glomerular basement membrane. And another thing is the urinary space is as what you know is just the in between the parietal and visceral layer. So this becomes the urinary space. So this is the urinary space which you can come across over here. Fine. So what you're looking at is the normal HND. What you're looking at is a normal HND and on light microscopy. Light microscopy. So this is a normal kidney. So what you're looking at is these are the parietal epithelial cells. These are the nuclei of the parietal epithelial cells. Okay. So we can write over here as parietal epithelial cells. So this being the nucleus of the visceral epithelial cells. Hope you can make out clearly that the food processes are not visible over here. And these are the capillary lumens. These are the glomerular capillary lumens. Glomerular capillary. In between these nuclei and these cells are nothing but these are the mesangial cells. And what exactly is this? This is the urinary space. This is the urinary space. And very adjacent to it, there are some cells with large eosinophilic cytoplasm. So these are nothing but the proximal convoluted tubules. These are the proximal convoluted tubules. Okay. This is also a proximal convoluted tubule. Yes. Next is about the normal glomerulus with some special stains. What is it called? PAS. Okay. PAS is para-iodic acid shift. We discussed that there are some special stains with which you can make out the compare the thickness of the basement membrane with the tubular basement membrane. See. So this is the tubular basement membrane and this is the basement membrane which you could able to appreciate over here. Okay. So this is the basement membrane of the glomerular. This is the basement membrane of the tubule with which we generally compare these two things. So this is the normal PAS of a glomerulus. Okay, the glomerulus still is very normally looking. It has no pathology identified over on this PAS also. Next, another special stain which is helpful to know about the membrane. This is another one is called silver stain. As you all know, silver stain will have a black colored appearance of the membrane. So all the capillaries are having this black lining. It is nothing but the basement membrane. See, it is very clear over here. This is the basement membrane, the black thing. Okay. So this is another special stain what we use. This image is very beautifully depicted and describes all the normal structures and all the normal functions of all the electron microscopic view of the glomerulus. As we discussed while drawing this image, imagine as if a small part of it is magnified. A small part of it is magnified and that one is this. So superiorly it is the glomerular capillary lumen. Means if you can extend like this, it will be like this. This is a glomerular capillary lumen. What you're looking at are nothing but the fenestrations, and I told you the fenestrations between the endothelial cells are of 70 to 100 nanometers, and what you're looking little outer aspect is this basement membrane. As such, basement membrane will be having your central lamina densa and inner laminar area interna and outer laminar area externa. This is all about the glomerular basement membrane, and we discussed about the components or the composition of the glomerular basement membrane is made up of type 4 collagen. Type 4 collagen again will be having alpha 1, alpha 2, alpha 3, alpha 4, alpha 5 and alpha 6. The most common trimer always will be alpha 1, alpha 2 and alpha 1. So what you're looking, other substances which form the normal glomerular basement membrane are collagen type 4, laminin, fibronectin, antractin, perlecan and heparin sulfate. So these are all the substances which build up the molecule of the glomerular basement membrane, and this after outside of which you come across the visceral epithelial cell, also called as a podocyte, which will be having the food processes. So here this is the visceral epithelial cell, this is the nucleus of the visceral epithelial cell, and outside you come across the visceral epithelial cell, you come across the urinary space or the Bowman space, wherein which all the urine will be filtered out, after which you have the parietal epithelial cell. So if you observe a very important thing, parietal cell has nothing to do with the filtration barrier. So filtration barrier is formed only by three cells, only by three structures, one being the endothelial cell, the middle one is the basement membrane, outer one is visceral epithelial cell. Parietal cell has nothing to do with the filtration barrier. So only these three structures put together called as a filtration barrier. So please be very clear. You may come across an MCQ in your physiology asking which of the following is not a part of the glomerular basement membrane. Sorry, is not a part of filtration barrier. Yeah. And as you all know, all black and white images are electron microscopic images. So this is the real electron microscopic image showing a normal glomerulus. So what you're looking at, these are the food process. These are the visceral epithelial cells. These are the visceral epithelial cells. These are the gaps between the visceral epithelial cells, which will be around 20 to 30 nanometers. And this is an endothelial cell. This is an endothelial cell. So what you're looking at is the basement membrane. This is the basement membrane. So this the central darker structure is the lamina densa, and outer one is the laminar area interna and externa. This is the electron microscopic image of this glomerulus. So this we are already discussing. The glomerular basement membrane normal dimensions are 300 to 400 nanometers. The significance of remembering the thickness of this is, in some diseases like Alport syndrome, it will be irregularly thickened and thinned out, and in another disease called familial thin membrane disease also it will be very much thinned out. And endothelial gap junctions always will be 70 to 100 nanometers, whereas the epithelial means the gaps or the spaces between the visceral epithelial cells will be 20 to 30 nanometers. Okay, you need to remember the statistics. Okay, fine. Yeah, this is the most common trimer. As I told you, alpha 1, alpha 2, alpha 3, alpha 4, alpha 6 are the 6 types of alpha chains present in the glomerular basement membrane. The most common trimer as such will be 1 to 1. So never been asked as a question, but this is one of a very important topic, and you can expect this as a MCQ in near future. The most common trimer combination will be 1, 2 and 1. Yes. And yesterday we are discussing about the newer stages of a chronic kidney disease. Earlier it was renal insufficiency, decreased renal reserve, renal insufficiency, renal failure and end-stage renal disease. Now it has been classified into stage 1 to stage 5 on the basis of the GFR. So kidney failure is called if the GFR is less than 15, okay, with normal or increased GFR is more than or equal to 90, with mildly decreased, with moderately decreased, severe decrease, and chronic renal failure. So the new classification of staging of a chronic kidney disease. Next one is, another important thing is a normal protein which is secreted by the tubular epithelial cell called Tom Hartzell protein, and many times asked MCQ is about which produces this Tom Hartzell protein. It is nothing but the thick ascending loop of Henle. Okay, so it is the thick ascending loop of Henle. So thick ascending loop of Henle secretes a protein called Tom Hartzell protein, which is a normal protein. This protein combines with some other substances and it forms the cast, and that cast is formed in distal convoluted tubule. So don't confuse with this. So cast as such is formed in the distal convoluted tubule, but Tom Hartzell protein is produced in the thick ascending loop of Henle. Okay, fine. Next one. Now next let's move into the cast. So cast as such, I told you, these are certain molds of left out or secreted protein with some added substances which will be seen excreted in the urine. So they have some significance. Each cast has its own significance. So we need to remember those casts in the conditions along with the conditions where it is seen. So normally this cast is formed in the distal convoluted tubule, and the most composition of this cast is nothing but the Tom Horsfall protein with some other added substances. So generally we come across in any dehydration or severe exercise, you come across a cast which can be seen in even normal healthy individuals, that is called as a hyaline cast. Why it is called as a hyaline cast is it is somewhat glassy, transparent, which you can only make out if the illumination is much decreased. So this is called as a Hyaline cast. So you may also come across a question which of the cast is not pathological. So the cast which is not pathological is hyaline cast, which can be seen in normal individuals or even after strenuous exercise. Next one, what you are looking at is a granular cast. So if you could able to make out, you could able to appreciate this outlines which are much granular. So this is called as a granular cast. So this is called as a granular cast. So granular cast also less number of cases it can be seen normal, and you may come across about what could be the composition of the granules. These granules may be a plasma, these granules may be some proteins or some granules of the WBC or maybe some other plasma protein. So this is all about a granular cast. This is also a granular cast. So next, what is it you're looking at is a RBC cast. What is it you're looking at? A RBC cast. How to make out that it is an RBC? If you could appreciate this is an RBC which is showing a central pallor. So here also you could be able to make out RBC with a central pallor. RBC with a central pallor. This is called an RBC cast. So RBC cast is nothing but along with the normal cast, these RBCs will be attached or studded to the surface of the cast is called as an RBC cast, which is specific of some glomerulonephritis, more specifically your post-streptococcal glomerulonephritis. So this is all about the RBC cast, which can be asked as a MCQ, which was already asked, I guess. So this is a RBC cast which is seen in post-streptococcal glomerulonephritis. So next, what you are looking at is a WBC cast. It is a WBC cast. So WBC cast in the sense the same the normal protein of which you come across studying of these WBCs. You come across studying of this with WBCs, which is more in favor of any tubular inflammations like your pyelonephritis and all. You come across the WBC cast. So pyelonephritis can be, you come across this WBC cast. And next and most important, if you compare this cast with this cast, so obviously it is looking much wider. It is looking much wider. So this is called as a broad cast with sharp angle. So this is called broad cast or broad waxy cast, which is characteristic and specifically seen in chronic renal failure. This was asked repeatedly as an MCQ. So what is this cast? So much larger dimensions, which is generally seen in chronic renal failure. This is called as a broad cast or a waxy cast. So with this we are done with the cast. Next, also have a look about the crystals. See, there are three things which can be seen in a urine. So three components can be seen in urine. One is cells, other one is cast, and the third one is crystals. The information what a cast can give is already what we discussed. These cells are already discussed. RBC, WBC, epithelial cells are only the cells which you come across in urine microscopy. And coming to the crystal, so as such, you know, there are certain types of renal caliculi, and respective renal caliculi will be having the respective crystals in the urine. So on the basis of which you could able to make out the composition of the caliculi which a person is having. Okay, or any severe dehydrations or severe electrolyte imbalance, also you come across this crystals. So calcium oxalate crystals, if you could able to make out, there is a peculiar shape called envelope shape. If you want, I can just draw this for you. So this is called an envelope shape crystal. So envelope shape crystal this is seen in calcium oxalate. So calcium oxalate, the most common cause is if you eat any diet which is rich in oxalate like spinach, tomatoes and all, this is one of the cause where you come across calcium oxalate crystals, or more intake of calcium also can cause this calcium oxalate crystals. What is the shape of the crystal is the envelope shape. You may directly come across an MCQ focusing giving a picture of this cast and giving a picture of this crystal and be asking you which stone the person may be having or what is the composition of the crystal and all. So envelope shape is generally seen in calcium oxalate. The next one is a triple phosphate. Triple phosphate, nothing but you may also come across this as also called struvite stone, also called as your staghorn caliculi. Okay, So you may come across a person may be having staghorn caliculi or a struvite stone, or you can also call it as a triple phosphate stone. The three phosphates which present in this triple phosphate, easy way to remember is remember as CAM. Okay, CAM. Calcium, ammonium, magnesium phosphate are the three phosphate. If you have an observation of the image which we focused, it has a coffin lid appearance. It has a coffin lid or coffin box appearance of the crystals. Okay, fine. So this is all about this. This is all about this triple phosphate or struvite stone or staghorn stone which have a coffin lid appearance of the crystals. Next one is about a calcium carbonate. So calcium carbonate, most of the crystals will be spherical. If you have a close resolution or closer view of this, it will be having some radiating lines all over. The characteristic feature of a calcium carbonate stone. It will be spherical with radiating lines to the center, that is of calcium carbonate stone. This is a calcium carbonate stone. Next is about the cystine stone. Most of the time it will be hexagonal. This is the shape of a cystine stone, mostly seen in cases who will be having this cystinuria, cystinosis, or any cystine related abnormalities. This being one of the hardest stone. So these patients who are having cystine stone are cannot undergo extracorporeal shockwave lithotripsy. They need to go for an open surgery. Another unique feature of the cystine stone is this stone, as soon as it is removed from the body, can change its color on exposure to the atmospheric air. So please remember three important things about cystine stone. This is the hardest stone. The reason why you cannot do extracorporeal shockwave lithotripsy, and this stone on exposure to air mostly changes its color. And next important thing about this being the hardest, what being the most easily fragmented stone is uric acid stone. Uric acid stone is not that hard. It is one of the stone which is very easy to fragment on ESWL. Okay, fine. And next, tyrosine is almost like radiating lines or some this fiber like appearance is seen with the tyrosine crystal. So this is about the tyrosine crystal seen in any tyrosine amino acid metabolism. Yeah. And this, while we are talking about other aspect of, you have three microscopies: light microscopy, electron microscopy, immunofluorescence. So light microscopy, what structures you see, you have already seen. What you cannot make out of presence or absence of food process, the exact thickness of the basement membrane you cannot make out on light microscopy, whereas the details of these two can be made on electron microscopy. So you can able to make out the presence or absence of food process on electron microscopy, the exact location of the deposits you can make out, and the exact dimensions of the basement membrane also you can measure on electron microscopy. And what we can make out on immunofluorescence, we discussed it is about the exact pattern of the deposit, whether it is fine granular, coarse granular, or linear you can make out, and you can also make out the composition of the deposit, whether it is IgG or IgM or any alternate pathway complement is there, or this classical pathway complement is there, or IgA is there. So these things can be made out on immunofluorescence. So this mostly is to give you a rough idea of the different types of deposits in a normal image. Okay, fine. So what you are looking at, so again get back to the normal orientation. So these innermost things are your endothelial cells. These are the endothelial cells, and this dark red color structure is your basement membrane, and this sky blue colored cell is your visceral epithelial cell, and these green colored cells are the mesangial cells. So let's see, or let's look on about this one. So what is this one, which deposit it is? So this deposit is seen in between your visceral epithelial cell and the basement membrane, so which makes it a subepithelial deposit. Okay, is it very clear? Yes, it is very clear. So it is a subepithelial deposit. Now let's move on to 2. So 2 is something related to which is again subepithelial, but it is close to the membrane. Okay, it is close to the membrane. So this is almost, this should be the exact way of drawing this. So this is called membranous deposit. So what is this? This is membranous deposit. And 3, so 3 is in between the endothelium and the basement membrane, so it is called subendothelial deposit. And 4 is what you come across as a mesangial deposit. So these are the deposits which you come across in different diseases over here. So subepithelial, membranous, subendothelial, and mesangial deposits we have already seen. Yes, the next one is about this cola color urine. So cola color urine is seen in specific of post-streptococcal glomerulonephritis, also called as diffuse proliferative glomerulonephritis. Now we started discussing fastly about the individual glomerulonephritis. We'll be discussing under only 3 headings. The first heading is light microscopy. Second one is electron microscopy. The third one is immunofluorescence. Now the first thing what we are discussing is about post-streptococcal glomerulonephritis or diffuse proliferative glomerulonephritis. Let's directly go into the details. So, and what is this? To make you remember about what is seen in diffuse proliferative glomerulonephritis is nothing but a hump. So whenever you come across the term hump, always remember diffuse proliferative glomerulonephritis or post-streptococcal glomerulonephritis in your mind. And what is the composition of the hump? You may come across a question. So the composition of hump is nothing but a deposit. The reason for asking this question is, in contrast to what they come across in the spikes and domes in membranous glomerulonephritis, spikes and domes in membranous glomerulonephritis are not deposits. They are the normal glomerular membrane constituents, but here a hump is only because of a deposit. So if you want to highlight a spike and a dome, you need to go for membrane staining by periodic acid shift or silver stain. But if you want to go for highlighting of this, you need to go for electron microscopy. Okay, so this is called hump. So coming to the light microscopy, say for example, I will be drawing here a normal glomerulus. See what has happened to the glomerulus. See, even a single glomerulus couldn't able to focus in this field. It means the glomerulus has very much increased. So what has happened to the urinary space? It has decreased. What happened to the capillary lumen? It has much narrowed. And entire mesangium is having proliferation of, this is a neutrophil. Okay, this is also a neutrophil. So you have multiple neutrophils in proliferating all over the mesangium. So this is all about the light microscopic features of diffuse proliferative glomerulonephritis. So once again I am repeating, size of the glomerulus increases, urinary space decreases, capillary lumen decreases, entire mesangium will be proliferated with neutrophils. And another characteristic and most important feature is this being the glomerulonephritis with maximum proliferation. Repeatedly asked question it is. What is a glomerulonephritis with maximum endocapillary or capillary proliferation? So this being a glomerulonephritis with maximum proliferation. So this is all about the light microscopy. Next, what we are looking at is the electron microscopy. So now what we are looking at the electron microscopy. See, this is the basement membrane. This is the epithelial cell. Yeah, and what you are looking at is the subepithelial deposit. So this particular subepithelial deposit gives a hump-like appearance. So electron microscopy, what it is showing? Electron microscopy is showing subepithelial deposit. And what is this? Immunofluorescence. Obviously subepithelial or subendothelial obviously will be appearing as granular. So this is nothing but the granular pattern. This is nothing but the granular pattern. And what is the composition of this? Is IgG and IgM and complement. So will the complement persist, or will the complement always will be decreased? No, it doesn't decrease, because as if the person after 4 to 6 weeks there will be spontaneous recovery. Though the person will be having hypocomplementemia, it will be quite normal after 4 to 6 weeks. This is called transient hypocomplementemia, which is a characteristic feature of diffuse proliferative glomerulonephritis. So with this we are done with the first glomerulonephritis. Next move on to the second glomerulonephritis, which causes nephritic syndrome. So this is your RPGN. This is your RPGN, and what is that you are looking at? The gross of RPGN 1, RPGN 2, RPGN is 3 is the same, and this gross is nothing but your, yes, it is a flea-bitten kidney. It is a flea-bitten kidney. So flea-bitten kidney is not only specific of RPGN, it can also be seen in, so we have already discussed, it is seen in HSP, it is seen in HUS, it is seen in TTP, it is seen in subacute bacterial endocarditis, it is seen in malignant hypertension, okay, and RPGN. So these are all the conditions where you come across a flea-bitten kidney. The details we already discussed in the earlier classes. So RPGN again is also called as crescentic glomerulonephritis. Yes. Now as you know that RPGN will be again of 3 types, 1, 2 and 3. 3 is the most common thing. So 1, you have only one disease in it called as Goodpasture syndrome. 2, you have SLE, IgA nephropathy and HSP. 3, you have W and M. I told you easy way to remember, vaginous granulomatosis, now called as polyangiitis with granulomatosis, and you have vaginous granulomatosis. Okay, so these things come under RPGN 3. And most important and easiest way to remember is, as you move from 1 to 3, the deposits will keep on gradually keep on decreasing. So here it is a membranous deposit. Here it is subepithelial deposit. Here you have no deposit. As you have no deposit, that's why it is also called pauci-immune. It is also called pauci-immune glomerulonephritis. Now let's have a look about each individual types of RPGNs. So the light microscopy of RPGN1, RPGN2, RPGN3 again is the same. See, the gross is same for 1 to 3. The light microscopy also will be the same for 1 to 3. So on light microscopy, generally we cannot distinguish whether it is 1, 2 or 3. You compulsory need an electron microscopy or an immunofluorescence to know the pattern of the deposit. Let's see what exactly is this crescent. See. So what you're looking at, there is a proliferation seen all over the urinary space. All over the urinary space. It is here over here, and this is this place over here. So this is called as a crescent. So very important is the composition of the crescent, which is repeatedly asked MCQ. As I told you, it is a parietal epithelial cell. It is a parietal epithelial cell with monocyte and macrophages. And what is the stimulus for formation of a crescent? It is a thrombin. And what is the significance of the crescent? More the crescent, poor the prognosis will be. Lesser the crescent, good the prognosis will be. So crescents have a prognostic value in diagnosing this disease. So this is all about the light microscopy. And what is very pathognomic and characteristic or hallmark of this RPGN is a rupture of the GBM. And I told you easiest way to remember is just because as the basement membrane is ruptured, then only there could be a gain of entry of the macrophages and monocytes from the capillary into the urinary space and reaching the parietal epithelium. So what is pathognomic of RPGN? Pathognomic of RPGN is always rupture of the glomerular basement membrane, which you could able to make out. See, this is a basement membrane and here it has been ruptured out, and here is the other end of the basement membrane. Next we'll discuss about membranous glomerulonephritis. Yes, next we'll be discussing about membranous glomerulonephritis. So membranous glomerulonephritis, what I told you, it happens in stages. Let's have a look about the sequence. See, in this image, the green colored cell is your visceral epithelial cell, yellow colored cell is your endothelial cell, this red colored cell is your mesangial cell. Don't stick on to the colors. Colors are not specific. Each diagram, the colors keep on changing. So this green colored cell is visceral epithelial cell, yellow colored cell is your endothelial cell, the sky blue colored structure is your basement membrane, and the red colored cell is the mesangium. Let's see what happens in stage 1. So stage 1, what is this black thing? Is a deposit. So deposit is seen only in between a visceral epithelial and a basement membrane. So makes it subepithelial. Very good. So initially you have a subepithelial deposit. Next, what happens in between two deposits? Could you able to appreciate this? Yes. The sky blue structure is coming in between the deposit. So this is called a spike. So what is the composition of spike? Repeatedly I am asking. The composition of spike is always basement membrane. It is not at all a deposit. So next, what has happened? See, the spikes have united. The spikes have united to form a dome. The spikes have united to form a dome. So this dome is also a composition or component of the basement membrane. So this is what happens in stage 3. Next, what happens? The deposit has gone much deeper, and compare this thickness with the thickness over here. So there is duplication of the basement membrane. There is duplication of the basement membrane just because the subepithelial deposit has gone into the deeper layers of the basement membrane, just because as if basement membrane has formed on and outside to the basement membrane. And last and the most important thing is, see, absence of foot process. So there are absence of foot process also seen in the last part of the disease of the membranous glomerulonephritis. Though absence of foot process is not specific of membranous glomerulonephritis, it is seen in the last stages of the disease progression. So this image is only to make you remember about the spikes. The most important thing is the composition is about the basement membrane, and it is seen in membranous glomerulonephritis. Okay, so this is a silver impregnation technique to just make you see the spikes, or just is to make you compare the basement membrane with this over here. So the basement membrane is much thickened. So this is a case of membranous glomerulonephritis. Yeah, this is also, see, this is the basement membrane. This is the basement membrane. See, the deposits coming into the deeper layers of the basement membrane, and there is a duplication of the basement membrane. So this is electron microscopic image of the membranous glomerulonephritis. This is also the deposits which are seen on membranous glomerulonephritis. Mostly they are granular, but some places it is looking linear just because as the deposit has gone into the deeper layers. Yeah, this is also a same thing. Okay, see, you could able to appreciate the spikes over here. You could able to appreciate the spikes over here. This is also an image of the membranous glomerulonephritis. Next, what is this? So this mostly will be looking quite normal. This glomerulus on light microscopy is looking normal. And let's see what is happening on electron microscopy. So on electron microscopy, what has happened over here is this is the capillary lumen. This is the this is a visceral epithelial cell. If you could able to make out, there are no foot process. So it looks like it is a case of minimal change disease. The reason for putting this normal glomerulus over here is normal. The light microscopy. The light microscopy in minimal change disease always will be normal. And the only change what you come across in electron microscopy is absence of foot process. So this is the second glomerulonephritis discussed so far which has no foot process. One is your membranous glomerulonephritis, and this is your minimal change. This is you also have one more glomerulonephritis where foot process are absent, that is FSGS, focal segmental glomerulosclerosis. Okay, fine. Now we are about to discuss about this focal segmental glomerulosclerosis. So this focal segmental glomerulosclerosis, the main important thing of putting this image over here is this is one foot process, this is another foot process. So two adjacent foot process will be having some proteins in between called nephrin and podosin. Any mutation in nephrin and podosin also causes some other specific types of glomerulonephritis, wherein which you come across FSGS. So nephrin, absence of nephrin, NHVS. And absence of nephrin on chromosome 19 causes congenital nephrotic syndrome of Finnish type. Whereas absence of podosin causes NHPS2. This causes a mutation in chromosome 1 and it causes steroid resistant nephrotic syndrome. Both are autosomal recessive. You have a third one which is autosomal dominant FSGS, which is because of actinin 4 deficiency. You also have TRPC6 deficiency can also cause FSGS. So what are the four causes of FSGS in this image relatedly? It is type congenital nephrotic syndrome of Finnish type, chromosome 19, and this is nephrin mutation. And next one is steroid resistant nephrotic syndrome. It is because of chromosome 1 deficiency, and the protein deficiency is podosin. And other things are actinin 4 deficiency, which causes autosomal dominant FSGS, and next one is TRPC6 mutation also causes FSGS. And other very important etiologies of FSGS will be obesity. So you have obesity. Next one is IV drug abusers or IV heroin addicts, renal ablation, unilateral kidney, any chronic obstruction, okay, your sickle cell anemia, okay. So all these are the causes of FSGS, and most commonly it is HIV. And what is the variant of FSGS seen in HIV? It is collapsing variant. So collapsing variant is a variant of FSGS which is seen in HIV individuals, and this is of worst prognosis. What variant of FSGS will be having good prognosis? Yes, glomerular tip variant will be having a good prognosis. See, this is FSGS. See, why it is FSGS is because it is a complete glomerulus. There is sclerosis. Sclerosis is something dark pink in color. So this dark pink in color is confined to only a part of the glomerulus. So it is FSGS. As we are not seeing many glomerulus over here, you can't comment upon focal in this view, but if you compare, if it is less than 50%, it will be focal, and if it is only a part of the glomerulus is involved, it is called a segmental. So this mostly will be FSGS. And what is this is also FSGS. You could able to make out the collapse of the capillaries. This is the collapse of the capillaries, increasing the space over here, and this is called collapsing variant of FSGS. And next one is Mpgn, Membrano Proliferative Glomerulonephritis, also called mesangiocapillary glomerulonephritis. And again you have Mpgn 1, Mpgn 2, Mpgn 3, of which the most common will be Mpgn 1. In contrast, Rpgn 1 to 3 most common will be Rpgn 3, but in Mpgn 1 to 3 the most common will be Mpgn 1. And here also you can appreciate the differences between Mpgn 1, 2, 3 on light microscopy. Light microscopy will be the same. So you come across a question as thyroid-like appearance of glomerulus can be asked. Not thyroid-like, lobular appearance. Sorry, it is lobular appearance. So lobular appearance of the glomerulus is characteristic and specific of Mpgn. Okay, just because of increased proliferation, the glomerulus will be seen in the form of a lobule. So this lobular pattern is characteristic and specific of Mpgn on light microscopy. You can distinguish Mpgn1 from Mpgn2 on light microscopy. Yes. So you need to go for an electron microscopy for a distinction of Mpgn1 to Mpgn2, and very important are the differences between Mpgn1 and Mpgn2. Mpgn2 also called as dense deposit disease. Also called as dense deposit disease. How does the differences between Mpgn1 and Mpgn2 are? So Mpgn1, you always have subendothelial deposit. Very important. You have very less number of cases where you come across a subendothelial deposit, of which the first one is Mpgn1, Membrano Proliferative Glomerulonephritis. And Mpgn2, you have intramembranous deposit, so that there will be splitting of the basement membrane or rail track or tram track appearance of the basement membrane. These are also characteristic of Mpgn2. See, if you could able to make out, so this is what is the splitting of the basement membrane or tram track or rail track appearance. And another characteristic difference between 1 and 2 difference is 1 will be involving the classical and alternate pathway, whereas 2 only will be involving the alternate pathway. So C4, C1, C2 will be normal, whereas only C3 will be decreased. This decrease in C3, is it transient or persistent? Persistent. The main importance hypercomplementemia in DPGN from Mpgn is DPGN, it is transient hypercomplementemia. After 4 to 6 weeks it will be normal, but what you come across in Mpgn2 is persistent hypercomplementemia. The reason for persistent hypercomplementemia is these patients will be having a factor in their serum called C3NEF or C3 nephritogenic factor, which has a C3 convertase like action. So always the C3 convertase will be active. So activating the alternate pathway. So the alternate pathway components being the C3 and your property factor B also will be accumulated in the deposit. So these will be persistently decreased. Yeah, this is what we are talking about. C3NF has this C3 convertase action. It has a C3 convertase action. So always you have activation of this, which has again in turn activates this, and factor B or the property factor will in turn be activated, and this alternate pathway is very active in patients with Mpgn2. Yes. So this is a light microscopy which is showing some homogeneous dense deposits in the mesangium. Yes, see. The mesangium is showing some larger deposits. The mesangium is showing some larger deposits over here, and mostly it will be a case of IgA nephropathy. Though I can't comment upon IgA nephropathy on light microscopy, because light microscopy, my finding is a deposit in the mesangium, a deposit in a mesangium. The same deposits on mesangium, if I do a immunofluorescence, if it turn out to be IgA, because as I told you, immunofluorescence can only tell you about the composition. If it turn out to be IgA, then it is called as IgA nephropathy. What is the other name for IgA nephropathy? Yes, it is Berger disease. And what are the important features? It is the most common glomerulonephritis worldwide. Okay, worldwide. And these patients mostly will be presenting with hematuria. And what is the IgA which is involved? It is IgA1. And what happens? There will be increased in polymerized IgA. So the serum levels increase. So many students think as IgA is depositing in the kidney, the serum IgA decreases is what you think, but it is not. It doesn't decrease. So the serum IgA increases, and that increased thing is accumulating in the mesangium of the glomerulus, and parallelly the defective galactolization is happening, so that whatever IgA is coming, that will be defective only. So galactolization which is defective, so polymerized IgA increases, and that is mostly seen in IgA1. You have IgA1 and IgA2, but this is more commonly seen only with IgA1. And next one is an electron microscopy which is showing a irregularly thick and irregularly thin basement membrane. This is from your Robbins itself. This image has been asked many times as an MCQ. So this is a glomerulus which is irregularly thick, irregularly thin at some side. So this is nothing but a electron microscopy showing a basket weave appearance, and this is nothing but Alports. The unique and pathognomic features of Alport, what we already seen, this is one of the glomerulonephritis wherein which you come across all the inheritances, though X-linked dominant is the most common among these things. And what is the mnemonic we have for this? 3, 4, 5. So 3 and 4 will be having autosomal inheritance, and 5 will be having X-linked inheritance. And this is one of other disease where you have some other associated abnormalities of sensorineural hearing loss, anterior lenticonus, and superior and temporal dislocation of the lens. This is about Alport. Next is about the diabetic kidney. Many times you come across an image which is showing some nodules, and that nodules are in between two capillaries. So this is called intercapillary nodular glomerulosclerosis. So this is the characteristic lesion which you come across in a diabetic kidney. So what is the characteristic lesion which you come across in diabetic kidney? Intercapillary nodular glomerulosclerosis. This is also called KW lesion. The full form is Kimmelstein-Wilson lesion. And very, very important is always diabetic changes or diabetic nephropathy depends upon the duration of the disease, not on the severity of the diabetes. So this depends upon the duration of the diabetes. And most commonly you come across diffuse glomerulosclerosis. So don't confuse the words common and specific. So if you come across an MCQ asking upon the most common change in diabetic kidney, go for diffuse glomerulosclerosis. If the person is asking about more specific finding, go for Kimmelstein-Wilson lesion, which is nothing but intercapillary nodular glomerulosclerosis. You have three more pathognomic features. What is the other one is the deposition of this is also seen around a capillary. This is called fibrinous cap. It's also called capsular drop. It's called fibrinous cap. And similarly, that substance also accumulates hanging to the parietal capsule. This is called capsular drop. So what are the other findings you come across in this? You have a capsular drop, you have a fibrinous cap. And next and most important repeatedly asked MCQ these days is you also come across some glycogen accumulation in the tubular epithelial cells. So what is this? You come across a glycogen accumulation in the tubular epithelial cells, and they are called Armani-Epstein lesion. So what are they called? Armani-Epstein lesion. So Armani-Epstein lesion is nothing but glycogen deposition in the proximal convoluted tubule of a patient of diabetes. So once MCQ has been asked as Armani-Epstein lesion is seen in in the glomerular capillaries, basement membrane, parietal cell, visceral cell, and a proximal convoluted tubule. So it is a proximal convoluted tubular epithelial cell which shows these changes, not the glomerulus which shows the change. And next and most important is a lupus nephritis. Lupus nephritis, very, very, very unique feature is lupus nephritis will be having class 1 to class 5 types of glomerular nephritis. As you move from class 1 to class 5, the severity of the glomerular disease increases. And another unique feature of SLE is you come across all types of deposit. You have a subepithelial deposit, you have subendothelial deposit, you have membranous deposit, you have mesangial deposit. That's why this is called as a full house phenomena. What is full house phenomena? So full house phenomena is seen in SLA because as you move from class 1 to class 5 types of glomerular nephritis, the deposits increase and the location of the deposits keep on varying. So you have all locations with deposits at the end of the disease. So it is called as a full house phenomena. And most important and repeatedly asked question is the characteristic lesions in SLA are called wire loop lesions. So what is the question? So earlier it was a direct question. That wire loop lesions are seen in, the answer is SLA. But now the trend has been changed. Now the question is more about which class of lupus nephritis shows wire loop lesions. It is class 4. Another question. Wire loop lesions in lupus nephritis are because of subepithelial deposit, subendothelial deposit, mesangial deposit, membranous deposit. Yes, it is subendothelial deposit. Subendothelial deposit. So please repeat all the questions on lupus nephritis. Lupus nephritis has class 1 to class 5. As you move from one class to other class, the severity increases and the deposits you come across all types of deposits. So it is called as a full house phenomena. And very, very important is class 4 will be showing the characteristic so-called wire loop lesions. And the reason for wire loop lesions are nothing but the subendothelial deposits. Okay. Yeah. So this is to make you remember about a wire loop lesion. See, these are the wire loop lesions. See. wire loop lesion, this is wire loop lesion, this is wire loop lesion. Okay, this is also a wire loop lesion, the characteristic subendothelial deposits. And next is about acute tubular necrosis. Now let's move on to the next topic of tubular interstitial disorders. So the first thing as what we already seen is acute tubular necrosis. So acute tubular necrosis is one of the most common causes of acute renal failure. So as we discussed, there are two types, ischemic and toxic. So though both have common clinical features, on looking at the microscopy we can tell whether it is toxic or ischemic. As told you, toxic always will be seen continuously. The involvement of the tubule will be continuous. Whereas in acute tubular necrosis caused by ischemia, it will be patchy and diffuse. So patchy and diffuse involvement will be seen in ischemic, whereas continuous involvement will be seen in toxic type. And next one is about the chronic pyelonephritis. So here also we have seen about contracted kidney. So contracted kidney, there are two types of contracted kidney. One is symmetrical and other one is asymmetrical. Asymmetrical we come across in chronic pyelonephritis. Symmetrical you come across in chronic glomerulonephritis. And chronic pyelonephritis, again you have two things in it. One is reflex, other one is obstructive. Which is more common? Yes, reflex is more common and the cause is vesico-uretral reflex. That is what you are looking here. So there is a defect in the insertion of the ureter over here. So whatever during the act of micturition, whatever urine is there in the bladder, that will be going backwards and touching the pelvic calcial system. As this happens mostly in the upper part and the lower part, so you come across involvement mostly seen in the upper pole and the lower pole of the kidney. So this is all about chronic pyelonephritis. And acute pyelonephritis, as such, you have three things. One is papillary necrosis, you have pyonephrosis and perinephric abscess. So what you're looking is a cut section of the kidney which is showing necrosed papillae, which is showing some necrosed papillae. So this is the necrosed papillae. So this is the case of acute papillary necrosis. As we have seen acute papillary necrosis, you have a lot of causes for acute papillary necrosis. The causes of acute papillary necrosis are diabetes mellitus, which is most common and repeatedly asked MCQ. You have NSAID abuse, you have sickle cell anemia, okay, and obstruction. So the four causes of acute papillary necrosis, you have diabetes mellitus being the most common cause, NSAID abuse is there, sickle cell anemia is there, and the obstruction, the four causes of the acute papillary necrosis. Next is about this is the chronic pyelonephritis kidney. What we have already seen, the most commonly seen is in the upper pole and the lower pole, and what is characteristic is the blunting of the calyces. Blunting of the calyces is a characteristic of this thing. And another feature, as what we discussed, is a normal insertion of the ureter into the bladder, which is very oblique, so it has a sphincteric action on all over the ureter. But here what happens is this will be directly inserting into the bladder, so this doesn't have any sphincteric action. So this being the most common cause of vesico-uretral reflex, which can be investigated on in an investigation called micturating cystourethrogram. This investigation is done during the act of micturation. And next is, this is the gross of the kidney showing gross irregular scars. This is nothing but chronic pyelonephritis. And the same thing, this is repeatedly asked image oriented MCQ, many times asked in AIIMS. So you come across multiple atrophied tubules filled with the secretions over there resembling a thyroid tissue. So this is called thyroidization. So thyroidization is specific of chronic pyelonephritis. Many times asked image oriented question. You also come across a clinical history. So he will be giving a clinical history. So female is having some reflux disease. So because of the reflux disease, on ultrasound examination, we have seen some irregular contracted kidney, the biopsy of which is showing this. So what is the diagnosis? It is a straightforward question. Whenever you come across thyroid-like appearance of the kidney, the best diagnosis always will be chronic pyelonephritis. The next one is a granular contracted kidney. A granular contracted kidney is seen in chronic glomerulonephritis. You come across in benign nephrosclerosis. In some cases of chronic pyelonephritis also you come across this granular contracted kidney, but it is specific of chronic glomerulonephritis. So chronic glomerulonephritis, you have many glomerulonephritis which ends up in chronic glomerulonephritis, but the most common always will be rapidly progressing glomerulonephritis. You have a membrano proliferative glomerulonephritis, you have Fsgs, all of which will transform into chronic glomerulonephritis. And repeatedly asked MCQ is, which has least chances of transforming into which has least chance of transforming into chronic glomerulonephritis? It is post-streptococcal glomerulonephritis, which has very least chances of transforming into chronic glomerulonephritis. Next, about the hypertensive changes in the blood vessels. Hypertensive changes in the blood vessels, you have benign hypertension, malignant hypertension. Benign hypertension will be less than 200 by 120 with no other features. Malignant will be more than 200 by 120 with associated neurological symptoms and any papillary edema. So benign hypertension, you have only two things. One is this hyaline arteriosclerosis. And next one is cystic median necrosis. And what is seen in malignant hypertension is this hyperplastic arteriosclerosis, which has a onion skin appearance. This is hyperplastic arteriosclerosis. And next one is necrotizing arteriosclerosis, where you come across fibrinoid necrosis in the wall of a blood vessel. Next is about the cysts of the kidney. The first and the most important is autosomal dominant PCKD, which is again of two types. Okay, autosomal dominant PCKD or adult onset autosomal dominant PCKD, which is of two types. It is because of a mutation in the gene polycystin. ADPCKD 1 is because of mutation in polycystin 1, and type 2 is because of mutation in polycystin 2. 1 is because of chromosome 16, 2 is because of chromosome 4. And on looking at the gross of the kidney itself, you could make out that it is ADPCKD because grossly it is bossylated. You have multiple cysts. All the cysts are filled with hemorrhagic fluid. But remember one very important thing: the fluid is not urine. So this is 1 and 2 are nothing but ADPCKD. So this is what you come across in ADPCKD. And another one is extra renal features of autosomal dominant PCKD are repeatedly asked MCQs. You also come across cysts in some other structures like liver, pancreas, spleen and ovary, but these cysts are not seen in the brain, because you will be given brain also in the options asking that cysts are not seen in. So brain doesn't come across any cyst. And another important feature is the only change in the brain is a berry aneurysm is seen. You come across colonic diverticula. And another characteristic feature is mitral valve prolapse. Here also you come across an MCQ on which valvular abnormality is associated with ADPCKD. He will be giving tricuspid stenosis and all, but it is mitral valve prolapse. And of all these things, what we have seen, the most common cause of death in a patient of ADPCKD is always a cardiac cause, maybe a hypertension, maybe a mitral valve prolapse. Is the most common cause of death. Though a berry aneurysm can rupture and cause a subarachnoid hemorrhage, that is less likely to be a cause of death in a patient of ADPCKD. Even chronic renal failure also can cause death, but that also less common than a cardiovascular cause being the most common cause of death in patient with ADPCKD. Next is what you are looking at is there are some cysts seen in the junction of the cortex and the medulla. So this is called medullary sponge kidney. This is called as a medullary sponge kidney, which is autosomal dominant. You also come across another disease wherein which you come across cysts seen elsewhere. So that is called nephronophthisis, which is one of the most common causes of chronic renal failure in children of autosomal recessive inheritance. Okay, fine. Next is about the malignant tumors of the kidney. The most common malignant tumor of the kidney seen in adults being your renal cell carcinoma, also called Gravit tumor or hypernephroma. So as you know that it has a lot of variants like clear cell variant, papillary variant, chromophobe variant, collecting duct variant, and this medullary variant of renal cell carcinoma. The most common here you need to remember about the chromosomes. So papillary, the clear cell will be associated with von Hippel-Lindau syndrome, and the chromosome 3, very important, repeatedly asked MCQs on chromosome 3, which is associated with von Hippel-Lindau syndrome. You have a sporadic and hereditary also. Hereditary will be bilateral and multifocal clear cell will be seen. So this is to represent about multifocality, and it can also be seen bilaterally, whereas sporadic mostly will be unifocal. It can be seen only in one foci. Okay, fine. And coming to the papillary variant, you have two hereditary syndromes associated with papillary. One is hereditary leiomyoma with papillary carcinoma, hereditary papillary carcinoma. The mutation is with MET proto-oncogene, and here the chromosomes are, you have a trisomy 7, 17 and Y chromosome loss will be seen over here. So this is all about this sporadic papillary carcinoma. And next one is very important is chromophobe. So you have chromophobe, where we have chromophobe carcinoma, which is one of the malignancies which has a plant cell appearance, which has perinuclear halo, which has colloidal iron special stain, which is helpful in the diagnosis, which arises from the collecting duct, and which is of very good prognosis. Of all variants of renal cell carcinoma, chromophobe variant will be having the best prognosis. Now this is a gross of kidney showing a yellowish tumor in the upper pole. So this is the most common gross of a renal cell carcinoma. This is the most common gross of renal cell carcinoma. And I told you there is one infection, there is one inflammation or infectious etiology which also presents as this yellowish mass in the kidney called xanthogranulomatous pyelonephritis, which is mostly mistaken with renal cell carcinoma. So renal cell carcinoma appears yellow in color. And next this is the image showing a clear cell. This is the most common histological type clear cell carcinoma. And next one is the papillary carcinoma. This papillary variant of RC. Sometimes you also come across samoma bodies also here. And next is this very evidently you could able to make out this perinuclear halo, which is characteristic of this chromophobe variant. Chromophobe variant is also associated with a familial syndrome called Butt-Hughes syndrome, so which we already discussed much earlier. This is the of a plant cell appearance, perinuclear halo, very good prognosis among all, and it also deals with chromosome 1 and chromosome Y loss. Okay, chromosome 1 and chromosome Y loss. It involves multiple chromosomes, multiple chromosomal losses, hypodiploidy. All these are associated with chromophobe. And the most common malignant tumor of kidney seen in children will be Wilms tumor. Wilms tumor will be having a triphasic. We have discussed triphasic means 3 kinds of cells will be seen in the malignancy. One is the epithelial cell, second one is the mesenchymal cell, and third specific thing is nothing but the blastomal component, which are small blue round cell like cells. Okay, these 3 things are seen over here. Coming to the associations of Wilms tumor, you have Dennis-Drash syndrome, Beckwith-Wiedemann syndrome, and Vager syndrome. Vager is Wilms, aniridia, genital abnormalities, and growth retardation, whereas Dennis-Drash mostly deals with the gonads. You have gonadal dysgenesis, you have gonadoblastoma incidence, and we have pseudohermaphrodites are seen in Dennis-Drash. Whereas Beckwith-Wiedemann, the easiest way to remember is Wiedemann is wide, means you have hemihypertrophy, macroglossia, visceromegaly, you have pancreatoblastoma, hepatoblastoma, and some mesangial sclerosis also is associated with Beckwith-Wiedemann syndrome. And there is one benign tumor of the kidney which has a brown in color with a central stellate scar. So this is nothing but your oncocytoma. Very, very, very important thing is oncocytoma will be mahogany brown in color and has a central star. And though there are some tumors which other than this will be having a stellate or central star. One is your nodular hyperplasia, which is seen in liver, and this one. Okay, so it will be having a stellate scar. And coming to the microscopy, these cells will be showing some eosinophilic granular cytoplasm, the so-called oncocytes. So these are nothing but the oncocytes. This is nothing but the oncocyte. And the reason for oncocyte or reason for eosinophilic granular epithelium is cytoplasm is because of extensive abundant mitochondria. These are because of mitochondria. There is a lipoma. There is a variant of lipoma seen in kidney called angiomyolipoma. See, grossly it is looking white and yellowish in color, which is more characteristic of lipoma. So it is angiomyolipoma of the kidney, which is associated with a neurocutaneous syndrome called tuberous sclerosis. So tuberous sclerosis is a very high topic in skin, one among the neurocutaneous syndrome. The other neurocutaneous syndrome also you need to have read very thoroughly. Okay, fine. So angiomyolipoma microscopy is showing fat, a blood vessel, and a smooth muscle cells. This is a blood vessel. This is a fat. This is a blood vessel, and these are the smooth muscle cells. This is called angiomyolipoma. This can cause spontaneous hemoperitoneum because of a rupture, and that is called Wunderlich syndrome, which we also discussed. Okay, fine. So this is a kidney specimen which is showing yellowish appearance. This is called xanthogranulomatous pyelonephritis. I told you this is one of the closest differential diagnosis for renal cell carcinoma grossly. Okay, and we also come across 1 or 2 specimens of nephrectomy, thinking the surgeon thinking that it could be a case of renal cell carcinoma, but to our surprise it turned out to be xanthogranulomatous pyelonephritis. So unless the surgeon confirms that it is RCC, even these days they are not doing any unnecessary nephrectomies. Okay, fine. So what is this xanthogranulomatous pyelonephritis showing? Is showing plenty of macrophages which are studded with fat. Okay, the xanthoma like cells. These are called xanthoma like cells are seen in microscopy of xanthogranulomatous pyelonephritis. And next one is there is a type of cystitis called malakoplakia. So malakoplakia is a type of cystitis wherein which you come across large plaques which are seen in the urinary bladder. The microscopy of which will be showing lamellated concretion seen in the macrophage, and these are called Michaelis-Guttman bodies. What are these called? Michaelis-Guttman bodies. So these are the Michaelis-Guttman bodies, and this is caused by Proteus. So these are the plaques which are seen in the urinary bladder. These are the plaques which are seen in the urinary bladder. Yes. And coming to the malignancy, so there is a bladder which is showing some polypoidal growth seen over here. So this is mostly transitional cell carcinoma. I told you bladder you come across most commonly transitional carcinoma, but in cystosoma hematobium you come across squamous cell carcinoma, and any persistent or patent urachus you come across adenocarcinoma. But the most common among all will be transitional carcinoma, and transitional carcinoma as such will be a low grade and high grade. So depending upon the pleomorphism. So this is all about all image oriented MCQs of the renal pathology we have discussed so far. Next we'll move on to the next topic, male genital tract and female genital tract.